for our next lecture on the treatment of neonatal infections, may we call on Dr. Robert Dennis Garcia.
To the scientific committee, thank you for inviting me. This is a great honor and a pleasure for me. I was last invited to speak here 20 years ago, and not since then. I'm hoping after this talk I won't be invited another 20 years from now. So my topic is neonatal sepsis, and I want to try to convince you that empiric treatment should address local experience. So this is the conundrum of neonatal sepsis. According to Richard Polin, he was tasked to write the Group B strep prophylaxis for newborns, or prophylaxis for the mother. No? At that time, the mother is to give birth to the newborn. And this is what they said. No? Ideally, medical practice guidelines should be based on the best scientific studies. However, doctors often rely on observational studies and the experience of practitioners when high-quality randomized controlled trials, as was said by Lisa, are not available. In pediatrics, nowhere is this more evident than in the evaluation and treatment of newborn sepsis. So if you look at the AAP recommendations, which seems to influence a lot of us, in the United States, Group B strep and E. coli most commonly cause early-onset sepsis. For that reason, ampicillin and an aminoglycoside are generally used as initial therapy. And unfortunately, many of you continue to follow this recommendation. Number two, cefotaxime is an alternative to an aminoglycoside. However, they do say that rapid development of resistance to cefotaxime occurs when used routinely in the unit, and its use is a risk for invasive candidiasis. What does the WHO say naman? Something similar to what the Americans say. Number one, use ampicillin or penicillin plus gentamicin for both early onset and late onset sepsis. With evidence of staph infection like cellulitis, carbuncles, furuncles, use cloxacillin instead of ampicillin. Number three, a third-generation cephalosporin like ceftazidime or cefotaxime is the second-line regimen. However, they say at the end that none of these recommendations is based on strong evidence of efficacy. So, are these AAP and WHO recommendations generalizable? Can we apply this to the rest of the world, including this country? So indeed, in a review by Obiero from the Pediatric Infectious Disease Journal from 2015, he said that in a Tanzanian study, 100% of Klebsiella and E. coli isolates were resistant to ampicillin. 68% of both Klebsiella and E. coli were resistant to gentamicin. In a rural Indian study, on the other hand, 100% of neonatal sepsis blood isolates, all of which were gram-negative rods, were resistant to both ampicillin and gentamicin. So the protocol did not work for those Indian babies. The European Society of Pediatric Infectious Disease made a review of newborn sepsis empiric treatments in developing countries, which applies to us. And this is what they say they found and said. Number one, reducing neonatal morbidity and mortality depends on an improved empiric treatment of newborn sepsis. Number two, we need a much better understanding of pathogens and their susceptibilities in our backyard. And number three, without improving this evidence base, which is most important, empiric antibiotic treatment of newborn sepsis will remain uninformed at the local and international levels. Okay, let's go to a quick case. No? A 35-weeker AGA girl was born by primary cesarean section due to fetal decelerations to a 32-year-old gravida 1 para 0. Pregnancy was uncomplicated except for a maternal UTI 2 weeks before birth. Apgar scores were 9 and 9, and the initial physical examination was normal. Baby was fine for the first 3 days. On the 4th day of life, the newborn becomes ill, and a sepsis workup was done. Antibiotics were started. 12 hours after the blood culture was done, the Bacti tech calls up to alert the NICU staff that there was growth of a gram-negative bacilli in the blood culture. Question: what symptoms would the newborn have likely manifested when she was assessed by the NICU resident to be ill? Fever, apnea, persistent crying, tachypnea, lethargy. What is your answer? The answer is tachypnea. Okay, so this is a study that we did 20 years ago, clinical manifestations of bacteremic newborns upon initial evaluation for sepsis at Cardinal Santos, 1993 to 97, 41 patients. As you can see, the only majority finding was respiratory distress. Majority means more than 50%. All the other findings were seen in a minority: gastric, GI bleeding, hepatomegaly, abdominal distension or ileus, apnea, bradycardia. So generally, the resident in the middle of the night will piece together 2 or 3 symptoms. No, the nurse will report that the baby became apneic, blood sugar was checked, and the kid was hypoglycemic, and now the abdominal circumference is enlarging, the baby is now having ileus. The resident says, okay, this kid is having breakthrough sepsis, and that's how evaluation starts. In a poster that we have outside, maybe you might want to see it, clinical manifestations of bacteremic neonates upon initial evaluation for sepsis, Makati Medical Center, 15 years, 2000 to 2015, 28 patients only. And these were the symptoms. The only 2 majority findings were tachypnea and oxygen desaturation. Everything else was seen in the minority: apnea, retractions, poor activity. The point of these 2 slides is that there are no specific and sensitive clinical findings that you will see in a septic kid. No? You have to use your head and put together 2 or 3 soft symptoms and decide that this kid is having breakthrough sepsis. What kind of infections are seen in the newborn? Just 2, bacteremia and pneumonia. Minsan may neck, madaling yung meningitis, we'll go 5 or 6 years without even seeing 1 case of meningitis. We don't even see UTIs. I sometimes hear other doctors say, look for UTI. UTIs don't happen in the newborn. Not tonsillitis, not pharyngitis, not otitis, not septic arthritis, not osteomyelitis. It's these 2. Case 2. When the resident in case 1 did her initial evaluation on a potentially septic 4-day-old X35-weeker, she requested stat lab tests, the results of which came back within an hour. Which of these lab results are most sensitive in detecting sepsis in a 4-day-old baby? A high white count together with a low platelet count, a high CRP together with a low white count, a high white count together with an elevated CRP, an elevated CRP together with thrombocytopenia, or a low white count together with a low platelet count? Answer. The answer is D, a high CRP and a low platelet count. So believe me, we've done local studies, but I don't have the time to show you. We have done 3 studies that showed that these are the most consistently abnormal findings right at the outset of evaluating a kid in the middle of the night. So you look for a high CRP and you look for a low platelet count. This is a study, again, out in the poster, most common lab abnormalities among septic neonates at the start of treatment, Makati Medical, over 15 years. Elevated CRP was seen in 43%, thrombocytopenia was seen in 32%, a high white count more than 30 was only seen in 18%, and neutropenia was only seen in 7%. But this just reflects the other data and other studies that we have seen locally as well as internationally. So CRP, this is one of our best useful tests that we can use to augment our clinical analysis. No? This is the old knowledge or the current knowledge about CRP. You need to do serial CRPs 24 to 48 hours after the start of symptoms. For instance, for a newborn baby who had maternal risk factors, you need to do a CRP at the 24th hour. You cannot do it at birth because it will be falsely negative. So CRP takes a while to go up. And then, number 2, repeated CRP checks 24 to 48 hours after the start of antibiotic carries a 99% negative predictive value in identifying non-infected newborns. So yun ang pinakasilbi ng CRP. Not its sensitivity, because it's not so great, not its specificity, not its positive predictive value, but its negative predictive value. If you have a couple of CRPs that are negative 24 hours apart, then that can tell you that you can probably shorten the antibiotic course to just 3 days instead of giving it 7 or 10 days. No? So its negative predictive value is what is most useful. However, CRP is not specific for sepsis, and the practitioners know this. No? It can be elevated among non-infected newborns in maternal fever, PROM, stressful delivery or fetal distress, perinatal asphyxia, meconium aspiration, surfactant use, IVH, respiratory distress syndrome, and even TTN. Ito naman yung new knowledge sa CRP. CRP values are lower in preterm compared to term infants. A dynamic reference value has to be used due to the CRP physiology in the first few days of life and the influence of gestational age. And number 3, diagnostic accuracy of CRP improves when combined with a newer test that's available for some of us, Procalcitonin. So this is the state of the art in other countries, but these are not available for us. But in the international literature, the best biomarkers that are available are amyloid A, interleukin-6, procalcitonin, and CRP. As you can see, CRP is at the bottom. No? It's inferior to amyloid A, interleukin, and even procalcitonin. So you see the sensitivity of CRP to be as low as 30% to as high as 80%. But its negative predictive value is not too far behind the other tests. Procalcitonin naman, for some of us here in Metro Manila, perhaps in Cebu and maybe Davao, procalcitonin is available. This one is a more sensitive indicator for newborn sepsis than CRP. It rises quickly within 4 hours, peaks at 6 to 8 hours, remains high at least 24 hours. Its value, however, is limited on day 1 and 2 due to a marked physiologic increase after birth. And this can be elevated up to 48 hours after normal birth. For instance, normally, for all of us here, if our procalcitonin is more than 0.5, abnormal na yun, no? Let's say we're admitted to the ICU because of septic shock. Anything more than 0.5 or 2.0 is abnormal. In a newborn, between 24 to 48 hours, the procalcitonin can be as high as 30 to 100. So napakasataas. No? So you cannot use it in the first couple of days. So this is a meta-analysis including 1,900 newborns that showed that the sensitivity of procalcitonin for early onset sepsis is 76%, and it's better for late onset sepsis with a sensitivity of 90%. However, in this study, they said that the heterogeneity of studies did not allow a firm conclusion to be made. Case 3, with the same 4-day-old baby that we had spoken about previously, X35 weaker, the blood pathogen is identified 2 days after the blood culture was obtained. Question, among the following, which organisms are likely to be the pathogen or pathogens identified? Group B strep, cons, E. coli, Klebsiella or Enterobacter, and Pseudomonas species. Answer. No. I bet you didn't get that. So Klebsiella or Enterobacter. And this is the heart of this talk. I want you to understand that gram-negatives are what we are up against in this country. So this is the evidence. We look for evidence, we will show you the evidence. This is a study we did 20 years ago, blood culture growth in neonatal sepsis at Cardinal Santos over a 6-year period, 48 cases. Enterobacter Klebsiella encompassed close to 70% of the organisms, no single case of group B strep. 3 studies from Makati Med that I combined in the interest of time, dating from 1995 to 2006 by Asuncion, Mercado, and Nishiyama. Cons was up to 67%. Enterobacter and Klebsiella were the second and third. Enterobacter up to 49%, Klebsiella up to 21%, Pseudomonas, and then Enterococcus, Candida. At the bottom of the list, we have Streptococcus agalactiae or group B strep. We had 3 cases of group B strep, and that was the 8%. So as you can see, it's mostly gram-negatives and Candida. This is a PGH study from 2002. Numbering 55 patients by Imperial, Enterobacter, Pseudomonas, Klebsiella, no case of group B strep. This is a multi-hospital study, but it was a small study, getting data from PCMC, Davao Doctors Hospital, Chonghua from Cebu, and St. Louis from Baguio. This is a 6-month study. Their organisms were Enterobacter, Klebsiella, Pseudomonas, E. coli, no case of group B strep. As you can see in the last 4 slides, Enterobacter, Klebsiella, Pseudomonas are the predominant organisms in different institutions. This is an outlier study. This is the only study that veered away from all the other data that we've seen. This is from PGH. I think they had a bad outbreak then in the year 2006. 122 patients, Pseudomonas putida, which is a non-aeruginosa Pseudomonas, encompass half of the isolates. Burkholderia malae, Burkholderia cepacia, another 23%. So this was a nasty outbreak from PGH. I am glad I'm not there. This is another study from Western Visayas, Cebu Doctors University Hospital, 3-year study, 108 patients. The organisms were staph species. I presume this is coagulase-negative staph. And then Enterobacter, Klebsiella. And this is the only report that reported Streptococcus species. I tried to email this lady, Dr. Maderal, but she did not respond to me. So we have no verification that this 10% of Streptococcus species were indeed group B Streptococcus. This is a study from Baguio General Hospital, 2004 to 2006, Enterobacter, Acinetobacter, Klebsiella. This is a study that we have out in the poster. This is the only study that tries to differentiate early onset from late onset sepsis. So this is a 15-year study, and you realize how clean Makati Med is. We have 2,000 deliveries per year, and we only have an average of 3 bacteremic newborns per year. And if you look at the early onset column, we have 8 or 1/4 of our early onset cases, 1/4 of all our cases are early onset, and 3/4 are late onset. But there was no single organism that stood out as a cause of early onset. We had 1 case each of Cons, Staph aureus, Pseudomonas aeruginosa, 1 Serratia, 1 Klebsiella, 1 Strep viridans, 1 Pseudomonas stutzeri, and 1 group B strep. So if you used ampicillin just for early onset sepsis, just for this, you will get 2 of these 8, but the 6 out of 8 you will totally miss. If you use ampicillin for the late onset organisms, you will totally miss everyone in that list. Now, this is my own personal list, Makati Med, over the last 15 years, 39 patients. These are my numbers, Cons, 23%, Klebsiella, Candida, Serratia, Enterobacter. Only 1 case of group B strep in the last 15 years. This is from UST Hospital. I'm very thankful UST shared their hospital. This is data for the last 10 years, 263 cases, or averaging about 26 bacteremic patients per year. And their numbers are similar to what everyone else has. No? Cons, Klebsiella, Serratia, Enterobacter, E. coli, not 1 case of group B strep. And this is PGH data. I'm also thankful to PGH for sharing this. 2012 to 2015, 725 bacteremic newborns. Oh my goodness, over 4 years in PGH. But look at this, Klebsiella encompassed 53% of isolates in the last 4 years. And then the others were single digits, Cons, Burkholderia, Candida, Pseudomonas, Acinetobacter. Not 1 case of group B strep. And then lastly, for this bacteriology list, this is data. I'm also thankful to PCMC. This was their data for 2016, 62 patients. Cons, Klebsiella, Candida, Serratia, E. coli, Burkholderia, not 1 case of group B strep. So this is the summary slide. So that was quite, paulit-ulit lang ako, but I wanted to make you understand that we got data from private hospitals like Makati and Cardinal. We got data from public hospitals, government hospitals like PCMC and PGH. We got data from teaching institutions like UST other than PGH. We got data from Baguio and Chonghua and Cebu Doctors Hospital and Davao Doctors Hospital. So we have data from everywhere. And this is the data. A summary of the common pathogen in 13 local studies in newborn sepsis, totaling a number of 1,764 positive blood cultures, and this is their ranking. Enterobacter, Klebsiella are the top 2, Cons, Pseudomonas species, Candida are the next 3, and at the bottom is group B strep. If you just look at group B strep, I only have 3 reports of group B strep out of 1,764. So you ask yourself, if you use ampicillin for any of these 11 organisms, anong tatamaan mo? Only group B strep, so parang 3 lang ginamot mo. No? Ampicillin will not work against Enterobacter, Klebsiella, Cons, Pseudomonas, Candida, aeruginosa, Serratia, Staph aureus, and Burkholderia. So our big problem now is the emergence of ESBL, extended spectrum beta-lactamases, and even worse, carbapenem-resistant bacteria. So at Makati Medical Center, our ESBL Klebsiella rate is 17%. Our ESBL E. coli rate is 22%. Our carbapenem-resistant Klebsiella rate is 5%. Our carbapenem-resistant E. coli rate is 1%. What does that mean? If you have an ESBL organism, you cannot use anything other than meropenem, imipenem, or ertapenem. Anything else will probably not work. Tazocin will not work. Ciprofloxacin probably will not work. Cefepime will not work. No? So that's our big problem now. No? So how do we come up with rational antibiotic guidelines? This is our problem. Reduced antibiotic susceptibilities threatens any possible empiric regimen we might come up with. No? There is really a need for improved clinical and microbiologic surveillance in order to shape current practice locally to us and recommend treatment guidelines. So this is my 1, 2, 3. I'm going to tell you what we're doing at Makati Med and Cardinal Santos. This is by no means a PIDSP recommendation. This is my and our own recommendations, and you appreciate the data na lang. No? But I've been following Pacquiao since he started boxing 20 years ago. He has his 1, 2, 3. No? Right lead, left straight, uppercut. So you need to have a 1, 2, 3 galaw also for newborn sepsis. And this is what we do at Makati Med. We start with Cefuroxime. No one uses ampicillin anymore for early onset sepsis. Many reports say that you will lose patients if your first move is not the correct move. No? If you lose patients from your first move. So if you give that 2 to 3 days to work, if not better or worse in 2 or 3 days, then you switch to the big guns. Carbapenem, like meropenem or imipenem, or piperacin tazobactam, not a third-gen cephalosporin. We have found out, based on analyzing our antibiograms, that if the Klebsiella will not be treated by the cefuroxime, it will also not respond to the cefotaxime. So might as well skip that move kasi kung binigay mo ng cefotaxime, you wait another 3 days to give that a chance to work. If that doesn't work, patay ka na. 6 na araw ka na nag-intay para gumaling yung bata, hindi mo na mahabol yan. Magdi-DIC na yan at multiple organ failure. So you try to save the kid with the second move with the carbapenem or the piperacin tazobactam. Now, if an organism grows in the second round of blood cultures and the organism is susceptible to cefotaxime, you can back up and you can downgrade your meropenem to cefotaxime. Now, after giving the big gun, the work doesn't end there. You have to reevaluate. So that's the step 3. Should you add vancomycin for cons? Should you add fluconazole for yeast? Should you change the tazocin to meropenem because you're up against an ESBL Klebsiella and the tazocin is not working? Or should you try cefepime? Or worse, if you have a Pseudomonas or like a Burkholderia, do you have to give cotrimoxazole or ciprofloxacin? So these are the other moves that we think about. So these are all the secrets of the infectious disease doctors. Binigay ko na lahat sa inyo ng lahat ng sekreto ko. So this is what we did in, this is a study by Nishiyama. No? So you can see how it evolved in Makati Med. No? From 1997 to 2001, more people were using ampicillin aminoglycoside. No? However, by 2002, because of what we were pushing, more people were now using cefuroxime plus amikacin more than the ampicillin. And since that time, up to now, more than 90% of the time, our staff doctors at Makati Med and Cardinal use cefuamic as an initial protocol. And look at this data. This is a separate data from Dr. Martinez, who I work with, who's an excellent neonatologist at Makati Med. And look at our sepsis-related deaths. During the times that from 1998 to 2001, when we were using ampicillin-based regimens, our sepsis-related deaths were as high as 14 per year, whereas from 2002 to 2006, our sepsis-related mortality was down to 1 to 2 cases per year only. When we used standardized denominators according to the number of births per year, you can see that our sepsis-related deaths per 10,000 preterms were much lower compared to the numbers in the 1990s. Of course, this does not reveal that there were other changes. No? We have good infection control in the year 2000s. There also was tazocin, cefepime, meropenem that came along. In the 1990s, we could only use imipenem and ciprofloxacin. So marami rin changes that will not be seen in this slide. No? And then look at this other slide by Nishiyama. Length of stay and overall mortality rate in newborn sepsis according to the antibiotic regimens. If you look at the first 4 antibiotic regimens, which were ampicillin-based, and the last regimen at the bottom, which was cefuroxime-based, the length of stay for the ampicillin-based regimens were from 21 to 27 days, and we shortened that regimen with the regimen of cefuroxime. That length of stay was shortened to 17, but more so, the overall mortality was anywhere from 10 to 20% for the ampicillin-based regimens, but only 1% for the cefuroxime-based regimen. And then the odds ratio of death in newborn sepsis, according to the antibiotic regimen started in this study, If you use cefuroxime amikacin, out of 72 patients, only 1 died. Whereas if you use ampicillin plus an aminoglycoside, 20 out of 147 died, so that the odds ratio of death when on a cefuroxime amikacin regimen was only 0.1. Okay, so to give you data from Dr. Celia Carlos from the Antimicrobial Resistance Surveillance Program that Chet also spoke about earlier. This is 2015 data. Look at ampicillin. Kung sabihin mo na lang, okay, ampicillin, we're not giving that for group B strep. I'm giving that for E. coli. 82% of the time, it will not work against E. coli. But look at the bottom, amikacin, 4%. Only 4% resistance by E. coli against amikacin. That's the reason why you give amikacin as your second drug. I've been in situations wherein we're on cefuamic, and the organism comes out, E. coli, resistant to cefu, and it was the amikacin that held the hand of the baby and prevented the baby from spiraling into a septic shock. No? So amikacin is much better than gentamicin. No? And you see meropenem at the bottom, only 3% resistance. Another organism, so Klebsiella is our other top bug. Even cefuroxime that we use will only work 1 out of 2 times against Klebsiella. So it's still not the perfect beta-lactam drug. No? And again, you look at the bottom, amikacin, only 7% resistance by Klebsiella. Meropenem, 12%. But look at this yellow ESBL Klebsiella rate. That is the national ESBL Klebsiella rate in the Philippines. 38% of Klebsiellas all over the world, all over the country, over 22 sentinel sites, will be resistant to everything else except for meropenem, imipenem, and ertapenem. So, having said that, what antibiotic regimen should you use? According to Bandari from the Journal of Pediatric Infectious Disease from 2014, the incidence and etiology of early and late onset sepsis in newborns is variable across all countries, which necessitates that antibiotic therapy be tailored in an institution-specific manner. Furthermore, again, the group of Celia Carlos from Antimicrobial Resistance Surveillance Program 2015 said that hospitals, and I think this chat also said this, hospitals should base their recommendations on how to treat Enterobacteriaceae, which includes Klebsiella, Enterobacter, E. coli, based on your institution's prevailing resistance pattern, as these vary from hospital to hospital. So the challenge for all of us here is that you should get your own organisms that grow in your nurseries, test your antibiograms. Now, if you're in a small institution in a far-flung city or town, then maybe you can use proxies for institutions close to you, like Cebu, Davao, and you can use the data that you saw here from Manila. But that will be much better than the data that you would read from a textbook of Nelson, which would influence you to still use ampicillin. And a year from now, we would have had another many hundreds of newborns that would have died between now and next year. Lastly, let's show you the local mortality rates. And this will again prove the necessity for changing our antibiotic protocols. Our own study from 1997, newborn sepsis, Cardinal Santos, 47% overall mortality. Enterobacter cases, 57% died. Klebsiella cases, 43% died. Another old study we had from Makati Med, newborn sepsis, 29% overall mortality. Klebsiella cases, 50% died. Pseudomonas, 50%. Enterobacter, 16%. Coagulase negative staph, 0. Kaya hindi kami nagmamadali mag-vancomycin. Hindi ka mamamatay sa conse. Makakaintay ka. But hindi mo pwedeng intayin yung gram-negative. Yung gram-negative, papatayin ka in 2 or 3 days. That Enterobacter Pseudomonas Klebsiella outbreak from PGH, Imperial, 90% mortality. This was reported from the PIDSP journal. Number 4, Pseudomonas outbreak from PGH, Pagkatipunan, 64% mortality. Number 5, Enterobacter outbreak from Cebu Doctors University Hospital, 56% mortality. Serratia outbreak at Baguio General Hospital, 29% mortality. So our Makati Med data, again out in the poster, our mortality was much lower, 20%. And my own list of patients in the last 15 years in Makati Med, we only have a low 13% mortality. Not to brag about it, but because we can understand quite well what goes on in our nursery, and because we have good infection control, we're able to keep down our mortality with blood culture positive sepsis. So conclusions, having a good knowledge of each NICU's prevalent organism and drug susceptibilities is essential to empiric treatment regimens. Number 2, Streptococcus agalactiae is an infrequent pathogen locally. For that reason, there is little use for ampicillin against blood culture proven sepsis. So having said that, I hope I will still be invited next year. Number 3, Klebsiella, Enterobacter, cons, Pseudomonas, Candida are the predominant pathogens locally. Number 4, a second-generation cephalosporin and amikacin is a reasonable empiric regimen for early onset sepsis. So again, that works for us in Makati Med and Cardinal. You have to find out what you want to do. Do you want to use ampicillin sulbactam? Do you want to use coamoxiclav? You can find out for yourself, you know? But I don't think it's acceptable for us to be starting with meropenem and tacin. I think that's totally unacceptable as first-line treatment. Number 5, a broad-spectrum beta-lactam drug, carbapenem or piperacin tazobactam, together with amikacin, are suggested for empiric treatment of late-onset sepsis. Number 6, any regimen needs continuous re-evaluation. Consider adding vancomycin and/or fluconazole or changing the gram-negative coverage for late-onset sepsis. Number 7, we need to monitor ESBL-producing E. coli and Klebsiella as treatment is narrowed to carbapenems for these organisms. Number 8, mortality rates are as low as 13% to as high as 90% locally, mostly due to gram-negative organisms. And number 9, good infection control is essential for any unit. Thanks for listening.
We would like to